Welcome. Today again we are continuing with the part 2 of knee joint. So today in this lecture we are going to learn about the relations of knee joint. Then we are going to learn about its movements and the muscles supporting the different movements, locking and unlocking of the joint. Then the nerve supply and the blood supply and the upper environment. So these much part today in this lecture we are going to include. Fine. So now in this we'll start today with the relations of the knee joint. Relations of the knee joint. So in this here we can see in this diagram. So what are the different relations of the knee joint? Surrounding the knee joints, what are the different relations? So anterior relation, then posterior relation. So anterior relation, posterior relation, lateral and medial. So these were all surrounding relations which we are going to learn. So with this diagram, some of the relations which we have shown over here. Now we'll see that this is the cut transfer section and all those muscles and the vessels and the nerves which are surrounding this knee joint. So first of all, we'll see with the anterior relations. Anteriorly. So anteriorly, the three things in the relation we know as to the patella, the ligament is attached. And then the bursa, so anteriorly the four bursas are there which is present anteriorly. So therefore in anterior relation the anterior bursae, so of course four bursae which I have said, so anteriorly the bursae, then second is ligamentum patelli, and third just behind the patella and between these condyles, so that is we can say that is our patellar plexus of the nerves, So these are the three relations. So what are the three relations? In the anteriorly, so that is the anterior bursae, then ligamentum patelli, and third is a patellar plexus of the nerves. So these are three relations anteriorly. Now posterior relations. So we'll see here this is all posterior relation. So posterior relation for our convenience will divide into the three parts. So in middle, exactly in the middle, means behind in the middle part, then posterior lateral and posterior medial. So therefore, because the relations are many, so in this part it will be convenient. What are the posterior laterally, what are the posterior medial, and what are in the middle. Now in middle, again we'll see the three relations. So of course exactly in the middle, behind the knee, in middle of the posterior relation. So these are the popliteal vessels. Now see these popliteal vessels, artery and the vein, popliteal artery, popliteal vein. So these popliteal vessels, then tibial nerve, and the genicular vessels and nerves. So that's the middle genicular vessels and nerves. So these are the three relations in the middle part of the posterior aspect. So posteriorly, so in middle part. So three relations which we have mentioned over here, already have shown with diagram also. So popliteal vessel, then the tibial nerve, and the middle genicular vessels and nerves. So these are the middle. Now we'll see the posterior lateral relation. Now you can see in this diagram. If you draw this diagram, so it is very easy to make out the points. So on posterior lateral. So posterior lateral relations again the muscles, okay, and then nerves. So it's very prominently what we see. So again here the three relations on the posterior lateral, this posterior and lateral aspect. So posterior lateral, so that is the lateral head of the gastrocnemius. This is a very big, large muscles, of course. So like what we can say, the calf muscles in that group. So that is a lateral head of the gastrocnemius. Lateral head of the gastrocnemius is one relation. And just along with that, that's the plantaris. Another muscle is a plantaris. And the third is the common peroneal nerve. This common peroneal nerve. These are the posterior lateral. This is a posterior. So these are the posterior lateral relations. Now, whatever we are finding over here, these are the lateral. So in the lateral relation, we'll see. I am talking here with the posterior lateral aspect. So posterior lateral only the three things: two muscles and one nerve. Very simple and very easy to remember. Lateral head of the gastrocnemius, plantaris, along with it. Clear? This both. And then this is a common peroneal nerve. This. Now similarly, we'll see the posterior medial aspect. So posterior medial. So again, in the posterior medial, the relations which we'll see same. Similarly, the counterpart with the gastrocnemius muscle. So here is a lateral head. So there will be the medial head of the gastrocnemius. So medial head of the gastrocnemius is there. Then semi-membranosus, semi-tendinosus, gracilis. So see, so now what are the muscles which we are finding over there? On that part we are finding this. So that is a medial head of the gastrocnemius, medial head of the gastrocnemius, then the semimembranosus and semitendinosus, and the gracilis. So these are the muscles what we are finding on the posteromedial aspect of the posterior relation in the of the knee joint. Now the next relation is already we have learned anterior and posterior relation, posterior lateral, posteromedial, these four relations I have said. Now medial relations. So on medial aspect. So on medially, so of course the muscles which posteromedial also comes in relation with that. So we'll see first medial relation. Medially the here four relations. So on the extreme, that is what sartorius. So sartorius muscle is there. Then the gracilis and semitendinosus. So these muscles are on the what we can say lateral on the medial aspect also. Sorry, on the medial aspect. So sartorius, gracilis, semitendinosus. Then great saphenous vessels and nerve. Great saphenous vessels. Here in the diagram is not possible to show that, but these are the so great saphenous vessels and nerves. The third relation is the semimembranosus again, the complete muscles that part. So semimembranosus and inferior medial genicular vessels and nerve, and inferior medial genicular vessels and nerve. So these are the four relations. So that means muscles and the vessels and nerve, only this. So all those muscles was posteriorly we have listed. So that same name you have to repeat. Clear? So only the added is here what sartorius. Sartorius, then gracilis, semitendinosus. Then the what we can say. So this great saphenous vessels and nerves. Then next is a semimembranosus and inferior medial genicular vessels. Similarly, on the lateral, now these are medial relation. So we'll see on the lateral relation. So lateral relation, laterally. So what we find again a muscles, that is a biceps femoris. So here again three relations. So biceps femoris is there. Then the tendon of popliteus. This tendon of popliteus, which accident comes. So the tendon of popliteus on the lateral aspect. So biceps femoris, tendon of popliteus, 2. And then the similarly inferior lateral genicular vessels and nerve. On the medial side was the inferior medial genicular vessels and nerve. Here on the inferior lateral genicular vessels and nerve. So these are the relations of the knee joint. So all anterior, posterior, medial and lateral, and posterior we have divided into middle, posteromedially and posterolaterally. So these are all about the relation. Next part we are learning is about blood supply. So blood supply, knee joint is always supplied by the anastomosis around the knee joint, and this anastomosis is the chief sources of this anastomosis, or this anastomosis formed by the all the arteries, what we can say relate with the thigh. So in the knee around. So these are especially the branches from the popliteal artery, then the branches from the femoral artery, then the branches from the what we can say anterior and posterior tibial artery. So the anastomosis, only you have to remember these vessels, these arteries, very common. In fact, even you will name that branches from only these arteries and not the specific name of the branch. Not the specific name of the branch, only the what you have to mention is 4 arteries which will participate in forming the anastomosis around the knee joint. And what are these arteries? These are the popliteal artery, then femoral artery, anterior tibial artery, and branches from the posterior tibial artery. So these are the branches which forms the anastomosis, and that anastomosis supplies to the entire knee joint. So here we have mentioned the names of this. So the 5 genicular branches of the popliteal artery, then the descending genicular branch of the femoral artery, then the descending branch of the lateral circumflex femoral artery, recurrent branches of the anterior tibial artery, and the circumflex fibular branch of the posterior tibial artery. So, better if you remember this branch's name is well good, or otherwise you can say the anastomosis. So, in blood supply you can mention the anastomosis around the knee joint and the chief sources of the branches from the four major arteries: popliteal, femoral, anterior tibial and posterior tibial. Only branches we have mentioned the branches of this, that is also sufficient. Okay, so this is all about this blood supply. Now next is the nerve supply. So nerve supply of the knee joint. So again, the three large nerves of the lower limb, so which from the thighs which goes and that branches of it surrounding so knee it's supplying. So these are the branch from the femoral nerve, branch from the sciatic nerve and branch from the obturator nerve. So even if you say the branch of these nerves, that is again what is expected. But if specification we can mention the femoral nerve through which branch? So normally through the branches of the vasti, we know the three vastus muscles. Clear? So vastus lateralis, vastus medialis and vastus intermedius. So most common with the vastus medialis, the branch. So that muscular branch and the branch from that supplies to the knee joint. So therefore femoral nerve through the branches of the vasti muscle. Then the sciatic nerve. So sciatic nerve through the genicular branch of the tibial and the peroneal nerve. And then the obturator nerve, of course obturator nerve it's having this two division, anterior and posterior. So that's normally posterior division, branches from that. So obturator nerve through the posterior division, it supplies. So this is with the what? Nerve supply. Okay, next part we'll see the movements. Now next part what we are learning is the movements of the knee joint. So movements of knee joint, so the main four types of the movements at the knee joint takes place. So very common, that's a flexion of the knee, extension of the knee. Then medial rotation of the knee and then the lateral rotation of the knee. So therefore flexion extension is a very common movement, takes place at the knee, and second is the rotatory, and we rotate only the medial rotation and lateral rotation. So these are the four principal movements with the knee joint. And the muscles supporting this. So therefore the muscles which produce this movement, so the principal muscles and accessory muscles, so that group what we will mention over here. So first we'll see flexion. So three main muscles, of course the flexor group on the clear. So back of the what we say the knee and back of the thigh. So these muscles. So therefore this principal muscles involved in the flexion is biceps femoris. Biceps femoris, semi-membranosus and semi-tendinosus. So these are the muscles and accessory muscles that support these. So these are other four muscles are the gracilis, sartorius, popliteus and the gastrocnemius. The gastrocnemius muscles of these calf, the leg. So therefore they help their accessory, they support. So these are the main muscles involved with this flexion. Now extension, quadriceps femoris. The only main muscles on the extensor compartment anteriorly. So this is the quadriceps femoris. So all the four muscles of the quadriceps femoris. So the quadriceps femoris helps in the extension and it is supported by the accessory muscles involved is a tensor fasciae. Tensor fasciae that also supports. Then the medial rotation. So medial rotation. So this is by the again popliteus, semi-membranosus and semi-tendinosus. Semi-membranosus on the medial side and semi-tendinosus. Clear. And then the popliteus. So that helps in the medial rotation and supported by the sartorius and gracilis. Whereas the lateral rotation. So lateral rotation, the lateral side muscle that is the biceps femoris only. So lateral rotation by the biceps femoris. So these are the movements of the knee joint with the muscles providing these movements. Next part what we are learning is the locking and unlocking of knee joint. So in today's topic this is a very important topic. Locking and unlocking of knee joint, because this is also asked as a short note and short note for 5 marks. And these are only 5 to 6 points and they are very simple points. So I will make it very simplified, explain to you and you will understand. This is very simple. Many of you find that they have this topic because many of the students those who do not read, and as a person who is not reading, so he is not knowing. So and when such questions come, so we find it is a difficult. But once we learn, it becomes very simple. So we'll see what is a locking. So locking of knee and unlocking of knee. So locking and unlocking of knee joint. So locking means what? Locking means what? So remember one very characteristic feature. Locking means what? Full extension of the knee joint. locking this mechanism. So this locking mechanism allows the knee in its full extension, and full extension of course always in a standing position, always in a standing position, always in a standing position. And of course this standing position is without any much muscular efforts. Very relaxed. When we stand, we stand very relaxed. So without any much muscular efforts. So then when the knee get completely, so that yes, is get completely locked. So that's a full extension. So now as per of how we can define, how we can say what is locking. Locking is mechanism. Locking is mechanism that allows the knee to remain in the full extension, remain in the position of full extension. That is in standing without any much muscular efforts. So that's the locking. Now, how this locking takes place? So now to understand this mechanism, so that's a very, so why this So now this locking, always remember, here one characteristic term what you have to understand is because of the medial rotation. For locking always medial rotation takes place. Medial rotation of the knee is always takes place in that locking in the standing, in the during complete extension. Now, how this mechanism takes place? So first point is what? We'll see that this antero-posterior diameter. Now see, we know in the femur there are the two condyles, lateral and medial. Now here even it is seen. So this lateral condyle and this is the medial. So this head of the femur is always towards the medial. Clear, no? So now in this, so this is in my hand. Of course, it's on the left side. So now antero for locking mechanism, antero-posterior diameter of the lateral femorocondyle. Lateral femoral condyle is less than that of the medial condyle, and because of this lateral condyle rotates medially, and its articular surface is fully used, whereas the medial condyle, its articular surface is free. Now this articular surface of the medial condyle, now it rotates backward, and this will also get used, and this will be in full extension position, and the knee joint become locked. So this is very simple mechanism. So now why the lateral condyle has gone towards a medial rotation? Because its diameter, antero-posterior diameter, is less than that of the medial. So first in the medial rotation, it's completely articular surface is used completely, and then the medial condyle, its articular surface is used by the backward rotation, and therefore this gets fully extended, and the knee joint becomes locked. Clear? Now, therefore, at this time, the two things is support. What are the two things? First is about ligament. So there is an oblique pull on the ligament, because when it's a medial rotation, and because of the medial rotation which is making it locking of the knee, so all these ligaments, so there is an oblique pull on the ligament, and therefore all ligaments become rigid and taut. And second support is by the extensor muscle, and we know that extensor muscle, anterior compartment, that is quadriceps femoris. So this is the extensor muscle. So now it is in full activity, in its full action. So therefore this extensor muscle, quadriceps femoris, so that helps in what we can say locking of knee. So these are the ultimately see the total 4 points what we have learned. Locking only involved with the 4. First is the definition. What is the locking of the knee? So what we can say, so this mechanism allows the knee to remain in a position of full extension. This is a standing position without much muscular effects. And why this takes place? Why locking mechanism takes place? Because of the result of medial rotation. And in the medial rotation of the femur during extension position. Second point is, so full extension of the knee is one in locking. Second is because of the medial rotation. Now medial rotation, why this takes place? Because the antero-posterior diameter of the lateral condyle is less than that of the medial condyle. So therefore the articular surface of the lateral condyle is fully used, is completely used, whereas the medial condyle is free. The articular surface is free, and that allows it to backward rotation. And when it goes towards backward rotation, so its articular surface is also get used, medial condyle, and the knee in its full extension become long. And this is supported by the oblique pull of the ligaments, which makes the ligaments rigid and stout. And second is the full action of the extensor muscle, that is the quadriceps femoris. So this is all about the what we can say locking mechanism. Now to unlock. So for unlocking of the knee. So what is unlocking? Is a total reversible condition. So make it is a reversal of the medial rotation, because locking is because of medial rotation. So unlocking is what? Reversal of medial rotation. So reversal of medial rotation, that is what? That is by lateral rotation. And lateral rotation is supported by which muscle? Popliteus. So that is unlocking. So even you can find yourself. So you get strained on your in your standing position. So give a stretch on your knee instead of fully extension. So you will find a pressure on your medial side. So your medial side, because of the femur condyles has rotated medially. So it's a medial rotation, this is a full extension. And now in full extension you cannot bend. And when you have to bend, again this is your extensor muscle which get pulled. So now when you relax it and when you bend, see you find. So when you bend your knee, so you find that is a effect on towards the lateral. So that's so lateral rotation takes place. So locking is by medial rotation and unlocking is reversal of the medial rotation, that is a lateral rotation. Locking is supported by the quadriceps femoris, extensor muscle, and unlocking is supported by the popliteus. So this is all about the locking and unlocking of the knee joint. And the last part, this is the last part of this topic what we are learning. So in applied anatomy, few of the list we will going to see. First we'll see structurally the knee joint is a weak joint. Yes, we know. Even the fibrous capsule we have seen that anteriorly it is deficient. So this knee joint is comparatively is a weak. Why it is weak? What reason? Because its articular surface are not congruent. Articular surfaces are not congruent. Joint is a weak because the articular surfaces are not congruent. What's meaning that congruent? So now they are not exactly in harmony. Why they are not exactly in harmony? Because the condyles are not of the equal shape and size. Here if you see the condyles of the femur, so these are larger and convex, whereas the condyles of this tibia, so in comparatively they are small and they are shallow. So they are not completely what we can say occupying. I mean what we can say, as they are not deep. So therefore to hold they are not sufficient of that much of strength. So therefore these articular surfaces are not congruent. So because of that this joint is weak. Clear now? So knee joint weak. So first reason we have clear, the articular surfaces are not congruent, means they are not in harmony. So the agreement between them, the harmony between them, the size is not equalized to hold them in a proper. So therefore they are not articular surfaces are not congruent. Second, tibial condyles are small and shallow. Yes, I have said the reason why they are not congruent, because the tibial condyles are small and shallow, and to hold the large convex femoral condyles, because femoral condyles are very large and these condyles are convex. So to hold them properly, so that much sufficiency is not with the condyles of the tibia. Is not with the condyles of the tibia. So that's the reason this joint is weak. So now we have mentioned why this joint is weak. So these two reasons are clear with that articular surfaces are not congruent and tibial condyles are small and shallow to hold the large convex femoral condyles. Now then if this joint is not strong, that is weak, and we have learned this is large and complex. So therefore what makes it is stabilized or gives a strength? So therefore stability of the knee joint is maintained by these following factors. And these are the four following factors what we have listed. So these are the cruciate ligament, the collateral ligament, the capsules, strengthening of the capsules, and then the iliotibial threads, which even the previous lectures we have mentioned, previous part. So now cruciate ligament, so this cruciate ligament we have learned that. So it maintain the cruciate ligament that maintain the antero-posterior stability. So that helps in a antero-posterior stability that help or maintain. Collateral ligaments, both tibial collateral and fibular collateral. So tibial medial, so tibial collateral and fibular collateral, these both. So these also maintain side to side stability. Whereas the strengthening of the capsule we have seen by the patellar retinaculum. So patellar retinaculum. So already I have said that ligamentum patelli and its side or either lateral medial. So that forms the retinophylla, and that gives the strength to the capsules anteriorly. So therefore, because anteriorly the capsule is deficient, so therefore that is strengthened by the petal reticula. And iliotibial tract, that plays a very important role, because in iliotibial tract also in this topic we have learned. So this stabilizes the knee joint. This stabilizes the knee joint during extension. Clear? So therefore it always stabilizes the knee joint. So these are the factors which helps and maintain and gives the stability to the knee joint. Applied anatomy. After the first part what we discussed, that is knee joint is weak and it is stabilized, and by the following factor what we discussed. Now next is the deformity of the knee joint. In the deformity of the knee joint, so here is a two part. So with the movement of the legs, so we can say that the angle between long axis of the thigh, and leg, that has some abnormal movement. So in that genu valgum and genu varum, these are the two terms. Now what is the meaning of this genu valgum and genu varum? Genu valgum, also known as a knock knee. So this is always the leg may be abnormally abducted. I will show you here. So you can see with this video parameter. So in that this knee, so this legs are what we can say is outward. So that makes the movements. So legs is having a genu varum, there is a abducted. So this legs are outward abducted. This is outward. This abduction. So some of the deformities, if you see some of the people, those who may have a deformity, so that is a outward. So that is abduction. So this is abnormal abduction of the leg. So that is called as a genu valgum. In genu valgum is a abduction, outward abduction. And in the another is a genu varum. So there is a bony. In bony there is a leg move abnormally abducted. So now these legs are like this inside. So legs are moved inside. That means in that genu varum, so that is abnormally adducted. Now this is a so that is a bow. So that's called as a bony. So these are the two basic terms what because of this long axis of the abnormality here takes place in this. So genu valgum, that is abducted, legs move, legs are abnormally abducted, and in the genu varum the legs are abnormally adducted. So these are the two terms. So why these are happening? This is because of the rickets. Rickets more common in the children due to the deficiency of the vitamin D. Clear? And also because of that the calcium is deficient. So both. Now because calcium, for the absorption of calcium, vitamin D is required. When vitamin D is deficient, so calcium is also deficient. And therefore in the young children, so the developing part, so therefore these bones, they do not get properly developed. So this rickets is one of the cause for this abnormality of the genu varum and genu valgum. Second is a bad posture, and third is a congenital abnormality. Now next part we will see the disease of the knee. This is very common. So disease of the knee like osteoarthritis in old age. So osteoarthritis, rheumatoid arthritis. So arthritis, inflammation of the joint. So because of that, the abnormal swelling takes place, and even it may be because of some infection. So infection may occur, and because of this infection, and maybe pus formation inside. So therefore, synovial cavity is there, synovial fluid is there. So abnormal increase in the fluid and the swelling of the synovial membrane that leads to the synovitis or what we can say arthritis. So swelling of the knee. Then the injury to the knee. In the injury of the knee, so very common injury to the menisci. So menisci, there is a twisting or a strain. So twisting strain causes the injury to the menisci, because menisci between the two of the both condyles of the femur and condyles of the tibia. So